Good afternoon. My name is Tia Teriak, and I'm pleased to welcome you to this month's What's Up Doc, our monthly lecture series brought to you by the Concord Hospital Trust. We want to take this opportunity to thank the Walker Lecture Foundation for their sponsorship of What's Up Doc. And we are proud to bring you the latest information on healthcare issues, providers, and treatment options available here at Concord Hospital. As you may know, October is Breast Cancer Awareness Month, and I put on my pink today to show support for this particular health issue. And today, we're bringing you a special panel presentation led by Dr. Sharon Gunsher, Medical Director at Concord Hospital Breast Care Center. And the focus of today's presentation is breast cancer risk reduction strategies. I'd like to introduce Catherine Kale right now, APRN. Catherine will take care of serving as facilitator for our panel presentation.
Good afternoon, everybody. I'd like to introduce Dr. Sharon Gunsher. She'll be speaking about chemo prevention and risk reduction surgery. Dr. Gunsher graduated from the University of Michigan Medical School in 1992. She completed her residency in 1997 at the University Hospitals of Cleveland. Dr. Gunsher joined the medical staff at Concord Hospital in 2004. She is the medical director at the Concord Hospital Breast Care Center. Please welcome Dr. Sharon Gunsher.
Hello, everybody. Good afternoon. So I think today's talk, multiple people are speaking about different risk reduction strategies. I'll be talking about surgery and medical management. Okay, so which patients are at highest risk for breast cancer? Most common risk for breast cancer is actually having breasts, so women are higher risk than men, but men do get breast cancer as well. If you've had breast cancer in the past, so having had a previous breast cancer puts you at higher risk for developing breast cancer. If you've had a biopsy in the past that showed a high-risk lesion, ductal carcinoma in situ, lobular carcinoma in situ, flat epithelial atypia, or atypical lobular hyperplasia. All of those things increase a woman's risk probably to about 20% from an average risk of about 9%. Women who have gene mutations are at much higher risk of developing breast cancer. The ones we think about the most are BRCA1 and BRCA2. And those confer, BRCA1 positive patients probably have a 60 to 70% lifetime risk of developing breast cancer. BRCA1 a little bit lower, up to 50%. But there are multiple other mutations that we test for today, and I listed some of them: TP53, P10, PALB2, CDH1, and CHEK2. And they all increase a woman's risk for breast cancer above that 10%. But none of these other mutations are anywhere close to the risk that you carry if you have a BRCA1 or BRCA2 mutation. Women with a family history of breast cancer are also at higher risk. And breast cancer is the second most common solid malignancy in women. So a lot of women will have a family history of breast cancer because it's common, but it's not really a family history. When I say family history, I mean multiple relatives with breast cancer, mother, grandmother, cousins, women who get breast cancer at younger ages in successive generations. Women who have dense breast tissue on mammography are slightly higher risk of developing an invasive cancer at some point in their life. And women who had chest wall radiation before the age of 30 or more than 10 years ago. And these are mostly women who were treated for Hodgkin's disease. At this point now, more than 20 years ago, with mantle radiation. Women who took exogenous estrogen are at higher risk. So women who took birth control pills It increases your risk, but it's very minimal. It's not a huge increase. People think that women who took fertility drugs are at higher risk, and they are slightly higher. It's probably not for fertility drugs. Usually it's because women who took fertility drugs either had late first childbirth or did not have children. Women who take combination hormone replacement therapy after menopause significantly increase their risk for developing an invasive breast cancer. If you don't have your uterus and you take just estrogen, it does increase your risk a little teeny bit, but not anywhere close to what the risk increase is if you took combination hormone replacement therapy. Other risk factors: the older we get, the more likely we are to develop breast cancer. Women who were never pregnant are higher risk for breast cancer than women who had their first pregnancy early on. Dense breast tissue, as I mentioned before, family history. Obesity is a big one. Women with a higher BMI are at significantly higher lifetime risk of developing breast cancer than women with a healthy body weight. And alcohol as well increases risk. We used to say that more than 2 drinks a day increase risk, but there's more recent data that shows that any alcohol at all significantly increases risk. What I try to counsel patients on is moderate drinking. I tell them no more than 1 a day. And if they drink wine every night with dinner, I ask them to try to cut back on that. So what can we do to decrease a woman's risk for breast cancer? Some of it's lifestyle modifications, and I was told not to talk about that. Megan's telling me my dietary.
It's okay.
Okay. Surgery, which is where I come in, and medical chemo prevention. So chemo prevention, there are a couple of different drugs that work. There are 2 major classes of drugs. There was a study called the P1. So when they started giving tamoxifen to women with breast cancer back in the 90s, they discovered that it cut their risk of developing a second breast cancer in half. So there was a study called the P1 trial that was done, and it was published, I think, around 2000, and they just gave tamoxifen to high-risk women. So women who had a biopsy showing a precancerous lesion, or women with a strong family history, and tamoxifen decreased the risk of developing a breast cancer by about 50%. You had to take it for 5 years, but it cut the risk. There was enough. The tamoxifen has a lot of unpleasant side effects, causes hot flashes, and then the real unpleasant side effects, it can increase your risk of endometrial cancer, increases risk of heart attack, stroke, DVT, and pulmonary embolus. So there was a study called the STAR trial, published in the early 2000s, that looked at giving a different SERM, a different selective estrogen receptor modulator called Viloxifene. Viloxifene is equivalent in decreasing risk of developing a breast cancer, and it has a slightly better side effect profile, lower risk of endometrial cancer. More recently, studies have been done to look at the aromatase inhibitors to see if they decrease risk of developing breast cancer. The aromatase inhibitors were started to be given after a study called the ATTACK trial in 2004. So those have not been around as long. And taking an aromatase inhibitor alone for risk reduction can decrease your risk of developing an invasive cancer, probably by about 40%. It's a little less than the benefit you get from taking tamoxifen or Viloxifene. But if you have a history of a DVT or a PE and you want to do something, you take one of those drugs instead. Oh, you can see I bounced around. Other risks of tamoxifen that I forgot to mention are it can cause cataracts. I actually just learned that when I was preparing for this presentation. Viloxifene decreasing risk is similar. The other benefit for tamoxifen and relaxifene are that it's really good for their bone density. So women who have osteopenia or osteoporosis, if they're taking a selective estrogen receptor modulator, it can help improve their bone density. The gynecologists actually use relaxifene a lot just for their women who have osteopenia. The aromatase inhibitors that have been studied for risk reduction are anastrozole and exemestane. They can only be used in post-menopausal women. In pre-menopausal women, they actually stimulate ovarian follicle production and theoretically increase your risk of developing breast cancer. And the big problem, one of the two big problems with the aromatase inhibitors is they're really bad for your bone density. If you're osteopenic or osteoporotic, they can make your bone density much worse. They also cause a lot of joint aches and pains, arthralgias, and 5 to 10% of women have such bad arthralgias from the drugs that they're unable to complete them. Surgery is also beneficial. You can have both of your ovaries removed. Removing both ovaries only decreases risk for developing a breast cancer in women with a BRCA mutation. If you don't have a BRCA mutation, removing both ovaries will not do anything to lower your lifetime risk of developing a breast cancer. It's commonly recommended when young women are diagnosed with breast cancer, but for those women, removing their ovaries helps decrease their risk of distant recurrence. You can have a risk-reducing mastectomy, so removing the other breast. And the important thing to know is that the risk of getting a second breast cancer is not nearly as high as people think it is. I see patients all the time, especially younger women, when they have breast cancer, and they tell me, just cut it off. I don't need it anymore. I don't ever want to get breast cancer again. And women, especially women with breast cancer, vastly overestimate their risk of developing a second primary breast cancer. For years, I've told women your risk of a second breast cancer once you've had one, about 1 to 2% per year, for a lifetime risk of about 10%. But recent data looking at extracted from a study called the Taylor RX trial, which was really done looking to help figure out who needed it, another test called an Oncotype score, showed that risk of second primary breast cancer at 10 years is only 1.4%. So combination of hormonal therapy, chemotherapy, radiation therapy significantly decreases your risk of second primary breast cancer from about 5% at 5 years in the 80s down to about 1.4%. However, risk-reducing mastectomy is very beneficial in women who have a BRCA mutation. So women who have either a BRCA1 or BRCA2 mutation, their lifetime risk of developing a second breast cancer is about 30%. So for women who have a BRCA mutation, I always counsel them about having bilateral mastectomies or a risk-reducing mastectomy on the other side. And for women who have a bilateral mastectomy, it does not completely eliminate the risk of developing a breast cancer. There's always a small amount of breast tissue left on the chest wall, and the surgery only decreases your risk only by 95%. So it does significantly decrease it, but it doesn't make it zero. And I counsel my patients who have bilateral mastectomy, they still have to come in once a year. They still have to have a chest wall exam. I don't do any imaging, but they still need to have the exam. The unfortunate thing about contralateral prophylactic mastectomy is that it's increased significantly over the last 20 years. In 2002, only about 4% of women had a bilateral mastectomy for their breast cancer. And the most recent data I saw, which is about 5 years old, it's 15% nationally. So even if you have a small stage 1 breast cancer, 15% of women nationally are having bilateral mastectomies. And it doesn't improve your risk of, it does not decrease your risk of distant recurrence, and it doesn't improve your overall survival. The only women who really benefit, and I know I said this before, are women who have BRCA mutations. The other thing to know about bilateral mastectomy, they have double the complication rate. And there are real and permanent complications from mastectomy. A short-term complication is seromas. About half of women who have a mastectomy develop a seroma. You can get wound infections. You can have necrosis of the skin flaps. Post-mastectomy pain syndrome. So it's very common. I see women years later and they have pain in the chest wall. There are some mobility limitations, a lot of shoulder pain. There are complications from reconstructions. If you have implants, the implants can become scarred and fibrotic. They can rupture. They move. If you had your own tissue, you could develop abdominal wall hernias. It's not a benign. Removing both breasts is not a benign procedure. And reconstruction's improved greatly in the last 35 years. It's still not perfect. It still has long-term complications. And the other thing I didn't mention is there are real psychological implications. Many women will say, cut them off, I don't need them anymore, I'm going to be okay with it. And then they come in to see me later, and it's really hard, and they really struggle. And I think when women are just diagnosed, there's a lot of fear and a lot of anxiety. And then once they're done with their surgery and chemo if they need it, and radiation if they need it, and they settle down, it's hard. You feel different, it looks different. There's no sensation over the chest wall. And that is something they almost always complain about. We can leave the nipples behind now, but they don't have sensation. They look different. And I thought this was important, that the American Society of Breast Surgeons endorses the American Board of Internal Medicine. It's called the Choosing Wisely campaign. Don't routinely perform a double mastectomy in patients who have a single breast cancer. That's all. Thank you.
Can I say something? That was great, Sharon. And I learned some stuff.
I learned a whole bunch of stuff here for it. I was surprised. Things have changed.
Things have changed. One comment you made about tamoxifen being out since the 90s actually came out in the 80s. And there was a solid decade there where it, again, it was used in women who had breast cancer only. And it was women, and we didn't have a very good way in the 70s or 80s to test for estrogen receptors. Even when we found a way, we had to have a fairly big chunk of tissue. Prior to all that, it was recognized that estrogen was a very key part of it. It was a very key part of some women's progressive breast cancer. So we knew that trying to eliminate estrogen was a thing. And women with metastatic disease, particularly bone, were subjected to not only having their ovaries out, but their adrenal glands out. And there was some miraculous out. Most people still died, but there was reduction in the majority of patients of this disease.
It bought them time, too. I mean, it divided a couple of years.
So when tamoxifen came out, was it going to be as good as that mutilating big operation? We used to do it all at the same time. And the answer was it wasn't as good, but it was damn close. And so this looked like a miracle drug in women. In some women, if they were estrogen sensitive, which became estrogen positive, you could test for it. So when tamoxifen came out in the 80s, that whole operation disappeared. Because even though it wasn't as good, it was so much easier. And there was a decade there until the 90s that there was very few complications from the drug, side effects. It took time to see these side effects.
To understand what they were.
And there was even talk, believe it or not, of putting it in the drinking water. We should have a drug like that for testosterone, and we have a lot of solutions to problems. That definitely ought to be in the drinking water.
Originally, wasn't it only given, I'm trying to remember if it was only given to post-menopausal women?
Yes.
Right? They didn't realize at first that it would work in
But there was
premenopausal women.
discussion about pre-menopausal also, which would have been really difficult. So all I could say is that, that the list of side effects continues to go on, but those numbers often are pretty small. It is an incredible drug. I guess that's what I'm saying.
Even though your risk of endometrial cancer is higher, your risk of death is equivalent because the endometrial cancers are low grade and they're picked up early.
And the initial recommendation had no time limit. Right now it's still what?
It's 5 years in post-menopausal women.
Yeah.
It's 10. But this is therapeutic if you have cancer. It's 10 years in premenopausal women, and consideration should be given for 10 years if you had a higher oncotype score or positive nose.
But initially in the 80s, it was like forever.
Yeah.
I had one patient who had documented biopsy-proven metastatic bone disease, went on tamoxifen. This was after we would have done an adrenalectomy, oophorectomy on her. And she'd been on tamoxifen about 10 years, doing well. And when it came out that we ought to quit taking it, her comment was, over my dead body. And if I quit taking it, I will be dead. And so I never stopped it because there is a role maybe for that in some patients. And she was one. So it was just an interesting period of time. So.
registered dietitians in the state of New Hampshire with a specialty certification in oncology nutrition. She's been working as an oncology dietitian at the Payson Center for Cancer Care since it opened in 2003. Here she continues to help patients manage side effects from their cancers and cancer treatments. She also inspires patients to make healthy food and lifestyle changes to reduce the risk of cancer and cancer recurrence. Please welcome Megan.
Bear with me for a minute. I have a red light on my pack. Good? Thought we were going for green. Okay. Well, thank you for the introduction, and thank you, Dr. Gunsher. So again, I'm Megan Ryder, the dietitian at the Payson Center for Cancer Care. Today I'll be talking about breast cancer risk reduction with diet nutrition. Good to have it. Hard to take it off, isn't it? So with 1 in 8 women being diagnosed with breast cancer over a lifetime, a lot of people are asking the question, what can I do to reduce my risk? Some factors such as genes that are inherited from our parents are things that we can't change, but there are a lot of things that we can change. In fact, about 85% of breast cancers occur in women who have no family history of breast cancer. So what's going on, or what are the reasons? Why would breast cancer occur? They occur due to DNA damage that can be the result of just the natural aging process. But also other factors like body weight, inactivity, exposure to environmental toxins that we'll cover today. So though there certainly is no one single food that is going to cause or cure cancer, following healthy diet patterns and, as Dr. Gunsher mentioned, looking at a healthy body weight are certainly factors that can influence the risk of developing breast cancer. So, you may have noticed when you go looking for information on this topic, anything nutrition related, there's a lot that's out there, and it can be overwhelming, it can be confusing. So today I wanted to talk to you about a trusted resource, kind of one of the gold standard in my field. There is a giant report that's put out by the American Institute for Cancer Research and the World Cancer Research Fund. About every 10 years, they publish this 700-page report on cancer prevention of all different types of cancers. And from that, they pull out 10 cancer prevention recommendations. However, in between those 10-year mark, they also are continuously updating the research, and they're publishing individual publications on certain types of cancers. So there are 2 publications that they've put out on breast cancer, and one is on prevention, and it looks at both post-menopausal and pre-menopausal breast cancer, and then there's another publication on breast cancer survivorship. So this particular report on the right, this is the one that's on breast cancer prevention, and it looks at 119 studies, more than 12 million women, 260,000 cases of breast cancer. So instead of just looking at one study here or there, which is easy to do, this really is a compilation of lots of different well-done research. And then the experts look at what factors increase or decrease risk of breast cancer, and then they rate the strength of that evidence. So they look at all sorts of things, from broccoli to fats to vitamin D to soy, to body weight, etc. And then they look at where is the strongest evidence that we have, looking at all this evidence. So this report concluded that there are 3 really important risk factors that are modifiable, that we have some control over. And those are aim for a healthy body weight, limit or avoid alcohol, and be physically active. So I will leave the third one there to our physical therapy team. but wanted to touch on the first two. So starting with that first risk factor on healthy body weight and breast cancer. So this report shows a few interesting points. One, that there is strong convincing evidence that excess weight and weight gain as an adult are strongly linked with increased risk of postmenopausal breast cancer. So postmenopausal breast cancer is the most common, much more common than premenopausal breast cancer. So that the weight there is quite strong. The second point is not a typo, but shows that there is strong probable evidence that excess weight may reduce the risk of premenopausal breast cancer. So interestingly, having extra body weight may actually be somewhat protective as a premenopausal woman, especially they found in the age ranges of 18 to 24 and estrogen positive breast cancer. Now, that's a pretty small window again, right? Premenopausal breast cancer is not diagnosed nearly as often as postmenopausal. We're also looking at a small age range and estrogen receptor positive breast cancers. But nonetheless, that was one of the things that they pulled out of this research. The third point, that there are indications of links between a healthy body weight and better survival after premenopausal and postmenopausal breast cancer. So researchers do not advocate using weight gain as a tool to prevent premenopausal breast cancer. It is still recommended across the board that people aim for a healthy body weight, whether you're a premenopausal, postmenopausal cancer survivor. But that's what the research says. So, why is it that body weight might be connected to, or is connected to, breast cancer? Well, we know that excess fat does increase estrogen levels, and most breast cancers are estrogen receptor positive. So that's one of the key factors. Excess body weight can also make the body insulin resistant and create chronic low-grade inflammation. And we know that there are a lot of ties between that low-grade chronic inflammation and its connection to cancer and also heart disease and other comorbidities. So this is a chart from the National Cancer Institute looking at cancers that are associated with overweight and obesity. And I just put this up because I think it's pretty astounding. There are 13 different cancers that are strongly associated with overweight and obesity. One of those, again, being breast for postmenopausal women. So one other point just to make is that the median age for breast cancer diagnosis is 63 years old, and many of those women are also, as we all age, living with other conditions like high blood pressure, heart disease, diabetes, and weight is also associated with all of those. So yet another reason to be working toward a healthy body weight. So a healthy lifestyle for a healthy weight. So this is certainly a really complex topic that can't be accomplished in minutes, but it's certainly a lot more than just calories in and calories out. And I would certainly suggest a real lifestyle change, all the things that we're talking about today, and not just, again, calories. Looking at an abundance model versus deprivation model. So thinking really just a change in mind frame, thinking more about the things that you can have and should have. We'll talk in a minute about plant-based diet and healthy eating choices, and really thinking about those kinds of foods and eating those foods in abundance versus thinking about the guilt associated with, oh, I shouldn't have had that cookie, I shouldn't eat this, now I did that, and that's not going to do anybody any favors, right? So thinking about what do you love, what do you enjoy, and let's work with that. The second point is being active, doing what you love, and limiting your sedentary time. Practice stress management and get adequate sleep. So we know that when you're really stressed, your body produces the hormone cortisol, which is connected to metabolism changes and increases in appetite, maybe poor food choices. Same goes for if you're not getting adequate sleep. Food choices, changes in appetite. What I would suggest are setting reasonable goals and timelines. So for example, setting one goal per week. Start small. You know, sometimes people, especially when talking about cancer, want to do it all, right? Go organic, go vegan, and for some people that works, but most people find that chipping away can be more successful in the long term. So for example, one goal may be adding one piece of fruit at breakfast every day this week. You do that for a week, works for you, then you move on to another goal and accomplish that, and then you develop a lifetime of real healthy habits. Surrounding yourself with support is always incredibly important. Your friends, your family, your coworkers, your medical team. I didn't make a note here about reaching out to a dietitian, but of course I would suggest that as well for support. My hope in my field is that if you meet with a dietitian, really it can be someone that they can go over what are you doing right now, what do you love, what do you not enjoy, what's it like at home, and really help you to figure out how you might make some modifications and get you started. So remember that even a small amount of weight loss can provide great health benefits. So again, that idea of sort of chipping away at small amounts. Research really does show that even a 5% weight loss can make differences in things like your blood pressure, your blood glucose, inflammatory markers in your body. So for example, if you are someone who's about 180 pounds and you wanted to lose 5% of your body weight, that's 9 pounds. We know that a healthy weight loss is losing 1 or 2 pounds a week. So say you lose 1.5 pounds per week, that would take about 6 weeks to get to that goal of 9-pound weight loss and to really have those metabolic improvements. So following a healthy eating pattern. So this is when we were talking about that abundance model. These are the things that I would want you to eat more in abundance. Plant-based foods. And that doesn't mean a vegan or vegetarian diet per se, but thinking about a plant-based diet, mostly plants, lots of plant foods on your plate. So enjoying things like vegetables, fruits, herbs, and spices. Again, thinking about the things that you love. People will tell me all the time, well, I hate broccoli. Well, then don't eat broccoli. There's so many other things that we can choose from. Eating fiber-rich foods, which are really good for your whole gut microbiome and also for cancer prevention. Things like beans and peas, whole grains, nuts and seeds. Enjoying water, tea, seltzers, but trying to limit the sugar-sweetened beverages. And again, because of the connection with body weight is very important. Eating more plant-based proteins, so those would be things like nuts and seeds, tofu, edamame, quinoa are all examples. And also enjoying fish, kind of that Mediterranean type of diet, which has been studied to be quite beneficial, especially with estrogen receptor negative breast cancers. And limiting red and processed meat. Again, doesn't mean that you can never have it, but really trying to cut back wherever you are today, maybe doing a little bit less often and working in more of those plant foods and fish. Choosing healthy fats. For example, plant fats like extra virgin olive oil and avocado, nuts and seeds, flaxseed, fatty fish, whereas you're trying to limit things like butter, full-fat dairy, fatty milk, and margarine. And this really is a great time of year if you're looking to still get out to your local farm and enjoy an abundance of winter squashes, and still there are lots of greens, fresh garlic, fresh ginger. There's just so much that's out there. So don't hesitate to get out this weekend. And then the last point, the second modifiable risk factor on that report is to limit or avoid alcohol. And Dr. Gunsher also mentioned this, but it's an important one. The research shows there's strong evidence that alcohol increases the risk of both premenopausal and postmenopausal breast cancers. There are lots of possible connections. One being, again, that alcohol increases estrogen in the body. It's just an irritant on its own. Ethanol, the base of alcohol, and its metabolite, noted there, both are known carcinogens. And alcohol also affects nutrient absorption. It can decrease levels of B vitamins, carotenoids, and fat-soluble vitamins, which may all also be connected to cancer. There's a dose response with increased consumption. The more you drink, the higher your risk. For each alcoholic drink consumed per day, the relative risk of breast cancer is increased by about 7%. The American Cancer Society recommends best not to drink alcohol at all. If you do drink alcohol, the recommendations for women being no more than 1 drink per day, and for men, no more than 2 drinks per day. And on the right here, I just have a graphic of what we mean by 1 drink, because sometimes you can fill a pretty hefty glass, right? So a 12-ounce beer, 1.5 ounces of hard alcohol, or a 5-ounce glass of wine are considered to be 1 drink. So if you do drink alcohol, I'd encourage you to take your glass out at home, measure out 5 ounces, pour it in just once, and then you'll get a sense of where that line falls on your glass and maybe where you should call it. Sure.
Megan,
Yeah.
the patients that you work with, do you find the majority or the minority know that alcohol is a carcinogen?
I don't know that, I think most people probably know that it's a bad thing, but I don't know that most people know why, or that you're actually ingesting carcinogens. Yeah, good question.
Do you know if, or maybe Dr. Gunsher knows, is there any kind of movement within healthcare professionals to have alcohol labeled as a carcinogen?
Yeah, good question. I don't know, I've not heard. Would you like to take that on?
My experience is people aren't aware that it's a carcinogen.
Yeah.
It's already labeled for driving and pregnancy, right?
Oh, right, yes.
That's out of bottle or again.
Yeah, but not beyond that, not beyond driving and pregnancy. Yeah.
Thank you.
It's easy to do.
Yeah. So that is all I have for you today, so I will pass the talk on to Austri. Okay. Thank you all. I'm not sure.
So we have 2 wonderful physical therapists with us today on the panel. Barbara Tyne-Baker and Austri Monette, both are lymphedema physical therapists. Barbara is a certified lymphedema therapist with many years of clinical experience. She has worked at Concord Hospital in the outpatient rehab since 2006. One of her areas of clinical interest and expertise is oncology and lymphedema. And we also have Austri Monette. She's also a certified lymphedema therapist. She has worked as an outpatient physical therapist at Concord Hospital for over 5 years. And she also has clinical interest and expertise in oncology and lymphedema. So welcome to both of you. And Austri will present.
So we are going to talk about some exercise-based interventions to reduce risk of breast cancer today. So we all know that exercise is good for us, right, in a bunch of different capacities. So it lowers the risk of many things aside from just cancer. So cardiovascular disease, it decreases our risk of developing osteoporosis, improves insulin resistance, has a positive effect on things like depression and anxiety. And it preserves joint and muscle strength and flexibility over time. And obviously there are lots of ways that that we can get exercise. So we think about those usual types of exercise, things that are maybe aerobic, like going for a run or going for a walk, getting out on our bikes, dancing. And aerobic activities can be done most days of the week, if not every single day, in different capacities. And then there's strength-based exercises, so things that we are doing with resistance or even just using body weight resistance to work on building strength. And things like that are usually done between 2 to 3 times a week to allow us some recovery time in between those sessions. Because as you know, if you've ever done a resistant exercise, you probably get a little bit sore after. And as Megan just touched upon a little bit, obviously it's important to also pay attention to proper nutrition and diet as well as exercise, especially if our goal is to reduce body weight. So studies show that exercise is among modifiable risk behaviors for breast cancer, and it can also be a modifiable risk factor for other types of cancer as well. So things like colon cancer, endometrial cancer, prostate cancer, and lung cancer. And breast cancer reduction can actually be reduced by about 25% when performed in an adequate amount of time and intensity. And specifically in those post-menopausal groups of women, it's especially helpful at reducing risk of breast cancer in that age bracket. So how do we know how much exercise is enough? So according to the American College of Sports Medicine and the CDC, all healthy adults, regardless of our medical status, should be participating in about 30 minutes 5 days a week or 150 minutes a week total of aerobic exercise at a moderate intensity interval, or vigorous exercise 20 minutes a day, 3 days a week. And it's also recommended that we do something for strength training and resistance at least twice a week as well. And what type of exercise is good? And that can really be pretty much anything that kind of meets those criterias. So activity could be occupational, so getting exercise and activity in during the day while we're at work. Could be recreational, doing things outside, maybe participating in a community exercise program, going for walks, getting on our road bikes, or just stuff around the house as well. There was a study that was done on kind of those subgroups of exercise, and it did show that things like recreational exercise, walking, cycling, and household exercise was better at risk reduction of cancers than just being active throughout the day when you're at work, so doing a little bit of extra stuff outside of the usual workday. And again, we know that age seems to matter as well, so exercising, especially over the age of 50, reduces our breast cancer risk. To do that.
It also decreases risk of recurrence. So
Yes.
exercising for that amount of time can cut the risk of recurrence in half above what you would get from just chemotherapy and hormone therapy. And women who were active, I just read the study when I was preparing for this. Women who were active and got that level of exercise before they were diagnosed and then kept it up did even better than women who started an exercise program after diagnosis.
Yeah.
But you still get, if you weren't active before, you still get incredible benefit if you started after.
Exactly. Another option for exercise, and this falls into a little bit more of that vigorous type of exercise intensity, is something called high intensity interval training, which I would say has been a little bit more in the pop culture of the exercise conversation within the last 5 to 10 years or so. So what is high intensive interval training? So it's a high intensity bout of exercise matched with a short amount of rest after, and repeating that for a shorter period of time. So one of the reasons why this is kind of attractive to some folks too is that, as we know, we need a little bit less time of that vigorous intensity exercise. So if we do this 20 minutes a day, 3 days a week, as opposed to doing something that's a little bit more on the moderate range for 30 minutes a day, 5 days a week, that cuts down on that commitment to be able to do that. So a little bit more attractive for some folks. They feel like maybe they can be a little bit more consistent with doing something like this, where they don't have to worry about doing it as much mixing the two, obviously, if it's something that's a new activity that you've never done before, you want to be safe with it. You know, don't grab the heaviest weights that you've ever picked up in your life. So start nice and low. Really focus on developing your form over time with activity, and then you can progressively increase resistance with certain exercises. Just like some of that strength stuff, we want to make sure that we give ourselves a little bit of recovery time in between our workouts, so 24, 48 hours, depending on how we feel after and how much lactic acid we get in our bodies in that post-exercise soreness. And this is a factor with every type of exercise, but we also want to consistently change it up too. If we're always only doing the same exact type of exercise at the same exact kind of weight throughout a lifetime, it's not really doing anything after a while. So we want to always make sure that we're progressively kind of increasing our challenge and potentially trying some new things as well. And remember, resistance does not just have to be, you know, grabbing some dumbbells and doing an exercise there. It can be body weight stuff. So it could be doing some sit-to-stands out of a chair, doing some lunges, planks, push-ups. So body weight resistance is great as well. So we've talked about the time-based recommendations of how you know kind of you're getting enough in throughout the week, but how else can you kind of justify if you're doing enough? So this chart on the left here, so there's some different columns about how it describes kind of what is a moderate-based exercise and what is vigorous. So in a simple descriptor, if you're doing a moderate-based exercise, it should be something that you can be able to maintain a conversation with someone, but you're still kind of working. And if you were to rate that on like a 0 to 10 scale, you might rate it at like a 3 out of 4 on a fatigue factor. You can also track your heart rate with exercise too to justify it if you want to be a little bit more objective. So moderate-based exercise would be between 55 to 70% of your heart rate max, which is an age-adjusted calculation. Vigorous exercise, if you're doing that, you probably cannot hold a solid conversation with a friend. So you might need to take some breaths in between words, that type of thing. Again, on that modified rate of perceived exertion scale, you would probably rate it between like a 5 or a 6 out of 10. And your heart rate max would be between 70 to 90%. Another great option for activity, and Megan touched a little bit upon just stress reduction in general, is yoga. So yoga is an ancient practice, and it's meant to bring balance to the physical, the emotional, and spiritual being. And it can be beneficial for healthy individuals as well as people who have a slew of medical comorbidities. And studies have shown that yoga practice has an immediate impact on downregulating stress and anxiety. And studies show that bi-weekly, so twice a week, yoga practice can lower our heart rate, our diastolic blood pressure, blood glucose, blood lipids, stress, and inflammatory markers. So all those things that we know can just help us live a healthy life and reduce loss of other types of chronic disease, not just breast cancer. I put a little link up here, and probably people on Facebook can reference it, but there's about a zillion different little YouTube videos and stuff that you could do. So box breathing is a really nice little way to, even if you just have a minute during your day, to help to kind of downregulate stress and just use a little bit of Zen time. So box breathing, essentially, so I'm going to draw a little box. So it's a 4-count breathing exercise. So on your first 4-second increase up the wall, you inhale, and then you hold your breath for your next 4 seconds. Slowly exhale on the next box, and then hold again. So even throughout the day, if you're sitting at your desk at work, if you've had a stressful day, if you feel like you need a 5-second timeout from what you're doing, box breathing can be a really nice little yoga exercise to utilize. And like I said, there's a bunch of different YouTube links that you can click on for like a little visual tutorial of how to do so. So tips for success. part of the hardest thing about exercise is getting people to commit to it and make it a lifelong success story. So number one, if you have some medical stuff going on, talk to your doctor first. Make sure whatever you're thinking about is going to be beneficial for you. You are ready to take part in. Number two, make sure you have some good footwear. So sneakers, something like that, especially if you're going to be outside doing stuff on the road. Find a buddy and make a commitment. So if you're not working out with a friend right next to you, just set up a buddy where you can maybe check in on a day-to-day basis and say, hey, did you work out today? This is what I did. What did you do? How did you do? How do you feel? Schedule your exercise time. So if you can make it a visual calendar or write it in a planner and check it off when you do it each day, that also really helps well with consistency. And it's okay if something comes up and you need to postpone it, but make sure you reschedule it. Don't put it off. Just say, oh, I'll get to it later. Make sure you set yourself another time to get it done. And remember, it's okay to start easy. You want to progress slowly so that you're successful over time. And it's important to rely on positive experiences when you're doing stuff. And of course, if you need some formal help, we might know some good PTs that you can come and see if you need some guidance. So just to summarize some of those big important factors that we just talked about, physical inactivity is one of the few established breast cancer risk factors. So we know that there is about a 25% reduced risk of breast cancer in women who perform those activities at the correct frequency and duration over time. And of course, you're more successful if you continue to do this over a lifetime and don't just stick with a 6-week program and then drop all your exercise after that. So stick to it.
She's a green living expert. She's going to talk about environmental risk factors. Deborah received a master's degree in education from the University of New Hampshire and spent many years in the health field as a certified athletic trainer. Deborah was the founder of an environmental green goods store in New Hampshire and is active in the environmental community. Deborah works for the Anti-Cancer Lifestyle Program as an environmental toxin and green living expert. She developed the online module and created the in-person version of the Anti-Cancer Lifestyle Program environmental pillar and has taught this since 2011. Deborah is a frequent guest lecturer at cancer support groups and organizations interested in a less toxic lifestyle. Please welcome Deborah.
You're with me as well. Okay, hopefully that is good. Yes, with the voice, can you hear me in the back okay? Yeah. Okay, great, thanks. Well, thank you for having me. As was said, I was in fact, I'm used to this room because we taught in this room for years with the anti-cancer lifestyle program that we had pre-COVID here. So the anti-cancer lifestyle program is a 4-pillar program: diet, exercise, stress reduction, and environmental toxins. It is a complementary program. It does not take the place of your traditional medicine. It is to go along with it so that you can also take care of yourself. So with regard to breast cancer, only about 5 or 10 of breast cancers are hereditary or genetic. So what are the rest? Well, it's a combination of behavioral, lifestyle, and or the environment. So your behavior and lifestyle can increase or reduce exposure to environmental toxins, carcinogens, and endocrine disrupting chemicals. And we know this, right? We have examples of this. So for instance, in cities, people have more cancer, more breast cancer because of the pollution. We know this with firefighters. They have a double risk of cancer. We know this from the 9/11 event. There is a higher incidence of breast cancer. These are extreme environmental toxins and exposures. We know it with smoking, right? What is smoking? That is hundreds of different chemicals, many, many carcinogens. And the question is, what's the threshold? What's the dose of all this? And I'm not sure we're ever going to know that. We can't do experiments on humans, right? And it's just such a complex subject because we're talking about massive amounts of chemicals as mixtures. How are they functioning? And we're still at the stage where we're taking one chemical and doing an experiment on that. So we are kind of way behind when it comes to that. However, we do know that when you take some of these exposures away, people who live in the country, you're not a firefighter, you stop smoking, your risk of cancer goes down, okay? So that kind of makes sense to me. So in the real world, in the home, things smoking, alcohol, personal care products, types of foods, cleaning and cooking practices, keeping your indoor air clean, etc. We'll go into a tiny bit of detail later. So how are we exposed to all these chemicals and toxins? The basic exposure routes are air, ingestion, and skin. So, and I've put them in order of importance. Believe it or not, air quality is the most important. The EPA says that your indoor air quality in your home is 5 times worse than the outdoor air. So just let that sit for a minute, okay? The EPA has determined that. So what can be in our air? Dust, off-gassing of volatile organic compounds, fragrance, mothballs, candle burning, cooking, cleaning, fragrance, wood burning, air fresheners, pesticides, dry cleaning, solvents, mold, radon, PVC shower curtains, okay? So these are all things that might be in the air. You can't smell them, so you don't know they're there. They're very, very tiny amounts. Dust is huge. It carries a whole bunch of chemicals along with the dust, especially flame retardants. It's interesting. So that's a huge exposure route. Ingestion, you have pesticides from food sources, burnt foods. I'm sure you've read about grilling. Food additives, inhaled particles, because when you inhale and you cough up a little something, sometimes you swallow it, so then it's ingested. Microplastics is a big subject now. Food contact materials is a huge subject, all the things that are on the linings that actually touch your food and then migrate into the foods that you eat. Cookware, contaminants in water, arsenic in New Hampshire, right? Plastic containers that leach, canned foods that leach, and drinks, whether it's reusable bottles, plastic bottles, or cans also leach. So that's another source of exposure. And then there's the skin, sunscreens, cash register receipts. You have BPA that's very unstable on a cash register receipt. You touch it, and within 10 minutes, it's in your bloodstream. Personal care products, soaps, nails, polish, fabrics, VOCs, airborne particles also can land on your skin and be absorbed. Does everything go in your body? Of course not, or we wouldn't be able to go swimming, right? So about 60% of the things that we're just talking about here can actually have potential to enter your body. So most chemicals or toxins or compounds take on the dose makes the poison saying, right? That's been around forever. The more you have it, alcohol is a great example. The higher the dose, the greater the poison. Some things are actually necessary, like nickel chromium. That's a necessary micronutrient that humans must have. But if you have it in very high dosage, it becomes a poison. So again, most chemicals take on this "the dose makes the poison" saying. However, there is a chemical family called endocrine disrupting chemicals or hormones, and they're chemicals that mimic, block, or interfere with hormones in the body's endocrine system. They're not carcinogens. They're not classified as that. but they can indirectly raise the risk of cancer. BPA is the flagship of that, if ever any of you have heard of BPA. It's a chemical structure that is very similar to DES or estrogen, and it mimics it, but not perfectly. But it can enter, it can connect to the estrogen receptors, and this is where we have problems with BPA and breast cancer risk. So many chemicals are actually both carcinogens in EDCs. Some well-known ones, like I mentioned, are BPA. We have flame retardants. Some of those are both. Pesticides, parabens, phthalates. They can really wreak havoc with the hormone system. Cadmium, PFAS is a large family of chemicals. Maybe you've seen it because we have some toxic polluted sites in New Hampshire, right? PFAS is for perfluorinated substances. There's about 9,000 compounds just under that family of chemicals, and a lot more that are under this category, this special category called EDCs. So EDCs do not follow the dose makes the poison. And that's the difficulty, is actually you can have a very, very low dose, just like estrogen in our body. It's a tiny, tiny dose, and yet it does so much, right? And that is true also with these chemicals, a low dose. So the Endocrine Society has come out and said, we cannot establish a safe dose. And that's quite remarkable when you're talking about these. So you have BPA, it's substitutes BPS, BPF, can mostly be, and I'm highlighting that because of its association with breast cancer. Those are mostly found in canned foods and canned drinks. So even though you think you're having a nice seltzer water in a canned drink, it is leaching BPA into that. Polycarbonate plastic, your classic Nalgene bottles, and cash register receipts are your places of most exposure for this particular endocrine disrupting chemical. So what can you do about it? Okay, so these are the actions that you can do to reduce your overall risk of health and breast cancer. Keep your air clean, okay? Be careful of what you eat and drink. Think about what goes on your skin. Minimize the use of plastics. Okay, a lot of EDCs are in plastics. Read the ingredients on labels of personal care products and foods. Use safe cleaning products. Don't use pesticides. When in doubt, do without, like canned foods. There are alternatives. So this is a huge subject matter. Again, I'm really kind of touching the surface here, but this would be a great beginning for you to reduce your toxic exposure. And the basis of our program, the Anti-Cancer Lifestyle Program, is the Precautionary Principle. So an active approach, taking preventative action in the face of uncertain harm, because we don't know a lot. We don't know everything there is to know about this subject. Unfortunately, our country goes by what's called the reactionary principle, which is why so many of these things are in the marketplace. We have not used the precautionary principle, but you can as an individual, okay, when in doubt. A couple of resources I just wanted to point out to you. EWG, the Environmental Working Group. Maybe you've seen this. They've been doing this for several years. They every year they go out in grocery stores all across the country and they test pesticides on conventional foods. And so they create the Dirty Dozen. Okay, these are the foods that have the most pesticides. So if you can, buy them organic. And then they also have the Clean 15. So because buying all organic all the time can get expensive, so they have also the Clean 15 list so that, okay, I don't have to buy those organic necessarily. So EWG comes out with this every year. Another great resource is the Breast Cancer Prevention Partners, and they have a page here, Glossary of Breast Cancer Exposures. And you can see the list of chemicals here. There are about 41 there, but keep in mind, just the PFAS category down there is 9,000 chemicals. So even though they have 41 clicks here, it's thousands of chemicals we're talking about. super resource. You click on one of those, huge page opens up, what it is, where it's found, what's the research. So I highly recommend this as a resource for yourself. The other program, the other organization that is doing a lot of research in this area and putting things together is the Silent Spring Institute. They're right out of Boston, which is super. And on their website, they have a mammary carcinogen list. And again, you can access that, open it up, huge database, lots of interesting stuff there, lots of resources, so if you want to learn more about it. But they're doing real science and really helping the public resource these things. If you're interested in the anti-cancer lifestyle program, you can take the environment module. That's the one that I was in charge of. It's about a 3.5-hour course. It is free. So even though I just touched on this now, it goes much more into depth online. Also, the other resources you see below here are the EWG database Skin Deep. And that is a list of, I think they're up to 87,000 products now for personal care products. And they rank them, which is great. And they list the ingredients, what are they, and all that kind of stuff. And I recommend that you stay in the green category for safety. EWG also has a database on cleaners, same sort of thing. They break down the information on each product and guide you as to what would be the least toxic product. So thank you very much. Again, I'm part of the Anti-Cancer Lifestyle Program. You can find me on Facebook, Cancer Free Home. I also have some ebooks that have come out on healthy kitchen, reducing toxins, and also creating a non-toxic nursery for new parents. So thank you.
Do we have any questions for any member of our panel today? Jen, any questions online?
No, but we have a great info Megan online, and we have awesome job Austrian Barb online, and we have nice job everyone. So we got some positive feedback. Thank you all.
Okay, and I'm sorry, I didn't see a hand go up.
Yeah, I have a question for Deb. The air, the environment, et cetera, and the list of everything seems just so overwhelming for me who works full time and tries to stay green as much as possible.
Yeah.
What, in terms of your home, what do you think is like the most bang for your buck?
I would say keeping your air clean is the biggest bang for your buck, but again, under that category are a lot of lifestyle changes, So, but that is the highest exposure. So if you can keep your air clean, that would be best. So vent when you cook, watch which candles you burn, what are the VOCs that might be in your house, be careful how you dust. You want to wet dust or wet mop and not create dust or keep the dust in the house. So keeping your air clean. It's a huge subject, which is why Megan, I think our first class called my section the Holy Cow class, and I'm saying that nicely. So hope that helped.
Yeah, I need a housekeeper.
Anything else? Well, I want to thank Dr. Gunsher and your team. It was fabulous. I hope everyone's enjoyed today's session, and we look forward to welcoming you in November on the 12th for What's Up Doc. Thank you. Have a great weekend.
Yes. Is it surgery day for you?
Yes, I was on call last night.